Hey, everybody. Good evening. I was by the Cancer Survivors Park this afternoon, and it is sweata weta, which is a good thing. And we're going to go ahead and get started after we let some stragglers get in. So I'll get back to you in about 2 minutes. See the numbers continuing to increase here. So all right, let's go ahead and get started. So I'm Jeff Jaguar, and I'm your host for the Cancer Survivors Park Alliance sponsored series on cancer prevention and wellness. Tonight, we are thrilled to have Lindsay Metcalf back with us. She's a certified genetic counselor and has talked to us before. A lot of information to impart, but she's going to talk to us about the importance of family history. And my own experience is that you probably need to make your doctor aware of any of changes in your family history, because they will ask you the first time they see you, but they may not come back to that. They'll ask you how you're doing, but they won't ask if any changes in your family history. Before we get started, just some housekeeping. The audience will be muted. That is not to make you be quiet. We want you to have questions. Those questions will be monitored in the chat feature, and I will ask those of Lindsay. As per usual, we are recording this session, and this will show up for later viewing, or if you want to talk to a friend about it, it will be on the Cancer Survivors Park website, which is cancersurvivorspark.org, as well as all the previous recordings from this series since we went virtual during the pandemic. So without further ado, Lindsay, thanks so much for being here, and we will enjoy your comments. And you got a lot of information to impart, so I will interrupt minimally. Not to say I won't interrupt, but I will interrupt minimally. So thanks for being here, and take it away. I think we're not hearing you, Linz.
Oh, yeah, Lindsay, I'm prompting you to unmute. Is it giving you? There you go.
Hey.
There you go. There you go. It's hard to impart information when you can't hear you. So
Right. Lip reading is difficult if you don't do it regularly.
That's what we were.
Oh, good evening. Thank you so much for the opportunity to be here. It's always a pleasure to support the Cancer Survivors Park and all the very meaningful work that goes into that. So thank you for having me. Like Dr. Jaguar said, my name's Lindsay Metcalf, and I am a genetic counselor. I've been a genetic counselor for over 20 years now. So
Whoa.
that's exciting. Yes. Yes. I started when I was 3.
Yeah.
Mm-hmm. Yep.
So you've seen a lot of changes.
Yes, I have. So please put questions in the chat. I know many of you are here probably because you're thinking of your own families, which is wonderful. So let me share my screen so we can look at some of the material that I've got for us today. Hopefully this will happen right now. There we go. All right,
That's great.
so let me make sure this is working here. Oh, there we go. Okay, so let me move this over here. Just getting, there we go. So we're going to talk about, mostly we're going to talk about hereditary cancer and what that is, who is a family that might consider themselves at risk to have hereditary cancer, but we're also going to talk about familial and sporadic cancer, because there are some differences between hereditary and familial cancer. We're going to talk about genetic counseling and testing and what does that look like? What does that involve? What can you learn from that? And then I'll touch a little bit as well about direct to consumer testing, because, you know, quite frankly, that's something that people are kind of familiar with. So I want to talk about that. It's sometimes helpful to start by explaining what I don't do. So, you know, this gentleman unfortunately is learning that his DNA is backwards, and he has a question about that. So it's good to know that nobody has perfect DNA, and I don't spend my time telling people that their DNA is backwards. So if we're thinking about cancer and what goes into your risk of cancer, you know, we have environmental factors, we have lifestyle factors, your diet and exercise. We have aging, which unfortunately none of us has figured out how to escape. And then we're going to spend our time today talking about the bottom factor, which would be genetic factors. We're going to come back to this slide several times because it's important. So if you put all cancer together, most cancer is not hereditary. So most cancer is what we call sporadic, meaning comes out of nowhere, seemingly, can happen to anyone. The smallest piece of the pie is the hereditary piece of the pie. So those are families where there's a known gene mutation, and we'll talk about that as we go, that creates an increased risk for cancers in the family that we can track based on who has that mutation in the family and who does not. The other category here, familial, is families that have had genetic testing that is negative, but still have more than the expected amount of cancer going on in the family that we would still want to manage.
You know, Lindsay, it seems like we've delineated so many more, and you're going to go ahead and look at some of the named mutations. We delineated so many more pathologic mutations or mutations of significance. But that 5 to 10%, I mean, I remember giving lectures 5-10 years ago, and it was still that. I would think that would be getting a bigger piece of the pie, but it hadn't changed yet.
Yeah, I mean, you might wonder that. I think it seems to be holding fairly stable, because interestingly, when we first started doing hereditary genetic testing decades ago, we were only testing families that looked very suspicious.
Right.
Now we're testing more families. Even we have individuals that come to us that don't have a particular red flag in their family. They're just curious. Right. And so we're finding out more about what do mutations really mean for a person, because we're seeing more mutations in people that maybe don't create as much of a risk as we thought before. There's still definitely ones that create a good bit of risk that we need to deal with, but yeah, it is surprising to most people that that number is not larger.
Right.
Yeah. So let's dig into hereditary cancer. Sorry, I'm moving fast here. If we go back to biology class, you might remember that our bodies are made up of cells, and inside of each of our cells, we have our DNA. And a chromosome is a large package of DNA. And if you zoom in on a chromosome, you see what you probably learned in school as the structure of DNA, that double helix or the twisted ladder. And so if you look at that structure, you'll see that in the middle, there's a group of colored pieces that look like the rungs of the ladder, and those are the G's and C's and T's and A's. That's basically the spelling of the gene, so to speak. So a mutation, quote unquote, in a gene is when there's something different that is causing that gene not to work, meaning a misspelled word or a typo. Now this slide is going to take me a few minutes to explain, because this is kind of the crux of what hereditary cancer is. So if I'm not sure if you can see my mouse here, but I'm circling around the top left of this diagram. So this is non-hereditary cancer. So remember, this is cancer that happens by chance, which is the most common situation. Something to know is that we have 2 copies of each gene. We get one from our mother and one from our father. So in this diagram, we're seeing one parent who has 2 copies of a particular gene, and another parent who has their 2 copies of that particular gene. Now, the types of genes that we're talking about here, we could generally describe them as what we call tumor suppressors. So those are good guys. Those are genes that you want to be working because they do what it sounds like. They could recognize when cells are going crazy in your body that might become cancerous and stop them from becoming cancerous. So that's a good thing. So these are good cancer-fighting genes that we're talking about. So another thing to know is that as human beings, we are all susceptible to having mutations just pop up in our genes. As we're sitting here right now, unfortunately, our genes are mutating. It's just a fact of life. Now, if we have a mutation pop up in one of these good cancer-fighting genes, typically the other one is okay, and it's doing its job and keeping things under control. But if more time goes by and the other one gets a mutation as well, then there's no good copies of that gene working. And so cancer is likely to show up. Now compare that pathway to this one at the bottom of the page, which is hereditary cancer. So this would be where a mom or a dad has a mutation in one of these good cancer-fighting genes in all the cells of their body, including their eggs and sperm, so that when they had a child, they would pass down either one or the other, but 50-50 chance they would pass down that mutation to a child. So if a person's born with a mutation that they inherited from a parent, they are not born with cancer. However, they are born, in essence, one step closer to cancer. So if you follow along here, that would mean, okay, time goes by and another mutation pops up by chance, and then cancer shows up. So the concept here is we're not talking about people that are born with cancer. We're talking about people that are born with a genetic mutation that increases their chance to have a cancer, but does not guarantee that they would have a cancer. That's another important point to remember as we go along. Another way of thinking about this is not exactly a perfect analogy, but it's good. So if you think of your body as a car, and if you think of this wall over here as cancer, tumor suppressor genes are kind of like the brakes of your cells. It keeps them from making too many copies of themselves and piling on top of each other and becoming a tumor. The gas pedal of your cells is what we call an oncogene, meaning that's the one that says, hey, it's time to make another copy of yourself. Let's do it. So that's another pathway that hereditary cancer can happen, is if there's an oncogene that is too active and the brakes are broken, then we could end up with a cancer. Now that you all passed Genetics 101, let's move to Genetics 102. So something that some of you may have heard of in yourselves if you've had a cancer, or your friends or family, is, oh, so-and-so had genetic testing on their tumor and it showed something. So this statement, I'm going to clarify. All cancer is genetic, but most cancer is not inherited. So at its basic definition, cancer is when cells have genetic mutations that make them misbehave. So if you looked at the genes in anybody's cancer cells, you're going to see genetic mutations because that's what cancer is, but most of those mutations just popped up randomly. So that's a terminology thing you might hear. The vocabulary associated with that would be a genetic change that's neither inherited nor passed on to offspring is somatic mutations. So that's an area of genetic testing that I'm not going to talk the most about here because we're talking about the types of mutations that we can pass to our children. Like Dr. Jagier mentioned, we have a long list of genes that are good cancer-fighting genes that if you had a mutation in one of them would give you an increased risk of cancer. Here's a partial list. Many of you have heard of the BRCA1 and 2 genes. We'll talk about more about those later. Couple of important points. So I get these questions a lot. Okay, Lindsay, why are we talking about hereditary cancer? It seems obvious that cancer is hereditary in my family because everybody's had it, or a lot of people have had it. Well, okay, let's stop and think. Well, cancer is unfortunately common. So about 1 in 3 people will have cancer in their lifetime. And the fact that, if you stopped and thought about how many people you know of in your family, well, you're going to see cancer multiple times and it'd just be chance. Also, families share environments as well as genes. So that's something that's kind of hard to tease out. Was there an environmental risk factor that was contributing to a high rate of cancer in a particular family? So what are the things that we would consider something as a concern, as a possibility that might make us say, okay, this could be something hereditary going on? Well, if we've got 3 or more people in a family with either the same cancer or cancers that tend to run together, and there's groupings of cancers that like to travel together. So breast cancer, if it's hereditary, likes to travel with ovarian cancer and prostate cancer, and there's multiple groupings like that. If we see early onset cancer, if we see multiple cancers in the same person, also certain types of cancer tend to have a little bit more than an average chance to be hereditary. So those would be ovarian cancers, pancreatic cancers, male breast cancer, even prostate cancer that's metastasized. Hopefully some of you on this group have had a colonoscopy. And if you have, and you had more than 10 polyps over your lifetime, that's something that would make us concerned about a hereditary situation. And there's others here. This is just kind of a real boiled down list. So what's this process? What happens when we have people come to us and we look over everything? Well, we ask a lot of questions about families. Who's had cancer in the family? How old were they? What type was it? Has anybody had genetic testing in the family? And then we kind of say, okay, this looks suspicious. Or, there were 8 people with lung cancer in your family and they all smoked a pack a day. Yeah, it's probably not a big hereditary concern. So we give an assessment about what concerns there might be. And then we talk about genetic testing. So some of the benefits of genetic testing would be, it helps us understand if we find something, what is your cancer risk more specifically? So we all have a risk of cancer because we're human, but what genetic testing can tell us is specific information about how high is your cancer risk compared to someone who didn't have that particular mutation if we turned up something. So we use that to come up with a plan, because the goal is not just to tell people, well, your chance for cancer is higher, good luck with that. That's not helpful. We come up with a management plan that's based on evidence-based interventions. So we talk about more intensive screenings for certain cancers. We talk about what has been proven to reduce the chance of those specific cancers that we turned up a risk for, be it lifestyle, be it medication, be it surgery. And then one of the benefits is family members. So, many times people come because they're just concerned about their children, which is a very valid concern. But we like to point out that, children want their parents to be healthy, and this can be helpful to you and them. So sometimes people ask, okay, well, what are the limitations? Well, the limitations would be, we don't always find clear answers. So we can get results that we call variants of unknown significance. Those are genetic changes that we typically are not concerned about. They're just continuing to research. Sometimes people who aren't prepared, who don't have adequate education before genetic testing, might learn something that they weren't sure that they were going to learn. about their cancer risk. Some genes, we just don't know completely how they operate. And important to know that if somebody did a thorough medical genetic test for hereditary cancer, it doesn't eliminate the possibility of hereditary cancer because we don't know everything about genes yet. And we also cannot ever eliminate the chance for sporadic cancers with genetic testing.
So, Lindsay, the variants of uncertain significance, we obviously are not concerned about those, but they do show up. And what we tell the patients is that the company and other companies that do these tests will monitor to see if they are coming up to be more significant from a pathologic standpoint. Have you unbelievably said you've been doing this 20 years. Have you had a VUS that actually you got noticed that's now become more of a pathologic process?
I have. It's pretty rare. It's pretty rare. But here in this slide is a more visual representation of those possible results. So on the right, you see positive, which means we found a mutation in a gene that increases cancer risk. On the left, you see negative, which means nothing looked out of the ordinary in those genes that we checked. In the middle is that variant category, and 95+% of those get reclassified to negatives.
Okay.
So we treat them like negatives unless proven otherwise. So that's an important point to understand going in, that there's not anything to be alarmed about there, but we do contact people in the future if anything changes on those. And they happen about 30% of the time. They're not rare. So how do we do genetic testing? Well, usually it's a blood test. Occasionally we do saliva, but we generally prefer to do blood. But if we have folks that are just terrified of getting their blood drawn, we can do saliva. We can also do over-the-phone consultations and coordinate saliva samples from home. So we have options to make this very convenient for people. It's sent out to specialty labs because it's not something that local hospital labs do. Usually takes 2 to 3 weeks to get results back. And the number one question is, will my insurance pay for this? So the good news is that most people pay very little for genetic testing. Insurance has criteria about, okay, if you have this or that going on in your family, they will cover the cost of testing. But if you didn't have what the insurance was looking for to cover your testing, the maximum out-of-pocket cost for people doing this testing is $250. So it is not as expensive as it used to be. If you had heard folks that said, oh, I had genetic testing 6, 8, 10 years ago and it cost $5,000, we are not in those times anymore, thankfully. So finances are generally not a barrier. The labs that we work with have very generous patient assistance programs for people that are uninsured or underinsured, and they usually pay very little or nothing for testing in those situations. I like to talk about common myths. So here's a good one. Breast cancer genes cannot be inherited from the father's side or passed on to sons. Men have just as much of a chance to carry gene mutations that increase breast cancer risk as women do, but based on the body parts that they have, they are not as likely to show a cancer because they don't have as much breast tissue as women. And many of the genes that increase risk of breast cancer can also increase risk of ovarian cancer, which men don't have. Mutations can skip generations. So no, genes can't like hop out of your body and float around in midair and then jump into your grandchild's body. Where this comes from is this concept that I mentioned a few minutes ago, that what we're talking about here is genes that increase risk of cancer, but not guarantee that you would have a cancer. So it's entirely possible for a mutation to be tracking from grandparent to parent to child, and maybe only the parent actually displayed a cancer because the grandparent just didn't, and maybe the child is too young to have a high cancer risk yet. So you're at higher risk to inherit the mutation if you physically favor the relative with cancer. That doesn't track because these things are not connected. Your physical attributes are not connected to these genes that we're talking about. If you're a carrier, there's nothing you can do about it. We already covered that because we do have evidence-based interventions. If you test negative, there's nothing more you need to do. Well, we'll kind of come back to that later, but we don't ignore the family history. So if you did genetic testing and it was negative and but there's still cancer going on in the family, we don't ignore that. You will suffer from genetic discrimination. Well, no, there's a law that was passed in 2008 that prevents health insurers and employers from discriminating based on genetic testing results. And in my years of doing this, I've never had a patient come to tell me that that's happened. We already talked about cost and insurance. The last point, it's better to wait till treatment is complete. So if you're going through a cancer and someone offered genetic testing, it can inform oncologists on your treatment in terms of sometimes hereditary cancers respond better to certain chemo treatments than others. So why would you want to know? Why would you want to do this testing? Well, all of these reasons here. Reduce your risk, help your family members, inform. I mean, this is not research testing. Sometimes people say, well, I want to do this just for the good of science. Well, most of the science has already been fleshed out for this type of thing. Family testing. So if you were to test positive, then your children, your siblings, and your parents would typically have a 50-50 chance to also have that. Testing is available for free for family members if a person tests positive for a certain time frame. The labs offer it, I think, for about 150 days.
So a young breast cancer who we determine is BRCA positive, and she has children, but it's unlikely that the children are going to manifest the disease that they're predisposed to until they get older. When do we recommend that the children actually get tested?
Mm-hmm. That's a great question. So what we look at is what are our peer-reviewed recommendations for management and when would that start? So for example, if it's a gene that increases risk of breast cancer, and the recommendations would be that at age 20, if a person knew they had that gene mutation, they would begin breast screening with MRI. Then we would say, okay, by age 20 is when your daughter would want to consider doing this testing. So we use the management guide. So when would they start doing something differently? At what age? And that would be when we'd say, okay, that's an appropriate time to consider testing.
And it's obviously with lots of these mutations, ovarian cancer is one of the risk cancers, at-risk cancers. And normally we can work with that patient so they finish their childbearing years before they would consider any kind of surgery to remove the ovaries.
Exactly. This is not a one-size-fits-all type of scenario. So I can speak for what we do here. We see patients back annually after we learn that they carry a genetic mutation so that we can be sure that that they have the most accurate information about what they can consider, because needs change as people move through their lifetime. So I've got a couple of specific examples because sometimes it helps to see something that's actually happened and actually played out to kind of cement these concepts. So what I'm showing here is what we call a pedigree, which is our fancy way of drawing out families. And to get your bearings, there are circles and squares are men, circles are women. And those numbers you see are the ages of those individuals. So if you look in the middle, this blue square with the arrow pointing to it is the patient that came in to see us for genetic counseling and testing, 45-year-old gentleman who had recently been diagnosed with colon cancer. He has 3 children, ages 14, 17, and 11. He has 2 sisters who have not had any cancer. His mom has not had any cancer. He does have an aunt over here with breast cancer and another aunt with leukemia. On his father's side, his dad had testicular cancer at 35. prostate cancer at 64 and lung cancer at 73. His grandmother on this side had colon cancer early as well. So we counseled this gentleman that genetic testing would be something appropriate for him to consider because of his younger age with his colon cancer diagnosis, coupled with the fact that there was another early onset colon cancer in his father's family. So he did choose to do genetic testing, and the testing that was done for him is what we typically order for patients as a baseline. It's a multi-gene. It's actually 84 specific genes that kind of cover the gamut of cancer types. What was found was a pathogenic variant. So that's our term for mutation. I've been using the term mutation through this because that's what most people would understand. A mutation in a gene called MSH2. Okay, well, let's dig into that. Well, this tells us, this chart is what I'm going to talk about. So this column is what is the risk of specific cancers listed here on the left. What is the lifetime risk of having that cancer if you have that gene mutation? So lifetime risk of colon cancer, 33 to 52%. It's helpful to compare that to the general population because, as I mentioned earlier, we all have a chance for any type of cancer. So, you can look at these numbers here and see, okay, colorectal cancer is a big difference from the general population. Uterine cancer is a big difference. Ovarian cancer is a big difference. So this situation is something that we call Lynch syndrome. So Dr. Lynch was one of the first people that kind of put these puzzle pieces together, that those types of cancers were being seen tracking together in families. And then later on, we got smart enough with the molecular genetics to figure out which genes were behind that. So there's actually multiple genes that can cause Lynch syndrome. But over here on the right is, okay, what do we do about that? Well, we would say beginning at age 20, if you knew that you had an MSH2 mutation, you would start a colonoscopy and repeat it every 1 to 2 years. The average person does a colonoscopy about starting at age 45. We would say consider hysterectomy and oophorectomy, which is ovary removal, after childbearing complete. Upper endoscopy screening, looking for the stomach cancer that you noticed is a little above average there, as well as some pancreatic cancer screening.
And pancreatic screening has never been overly revealing. And so we haven't routinely done that. Over the last 5 years, however, there's been more and more protocols for effective pancreatic screening. And that is finding it at a time when it's still potentially resectable or operable and curable in that regard.
Right. Yes, the average person does not do pancreatic cancer screening because it's not a population screen like a mammogram. But in these families where we have a documented increased risk of pancreatic cancer, it is warranted. Mm-hmm. So this is the same family again. So I wanted to follow up. This question is kind of what you were asking before. So in this family, I first met this family about a year ago, and just a few weeks ago, which is why this was fresh on my mind. This young lady is now 18. And she, knowing what I just mentioned about starting colonoscopy potentially at age 20, if she were to have inherited this mutation from her father, she was a well-informed, bright young woman, and she said, I would like to know this information. I'm comfortable going ahead and knowing it now. She proceeded with genetic testing, and she did, in fact, inherit the MSH2 mutation from her father. So we will, proceed with colonoscopy for her in the next year or two, and hopefully, have a different outcome, because the goal here is we want to prevent cancers. So it's an interesting thing, because a lot of people might think, oh, I don't want to know. I'm surely I don't want to be positive. I just want to be negative if I did this test. Well, normally it takes people about 24 or 48 hours to kind of come to the conclusion that, it's actually kind of a good thing that this was found out, because this was information that was not available a generation ago and has the potential to change a family tree. let me give another real life example here. This one's a little smaller. Sorry, it's hard to read, but the individual that came in was this 43-year-old woman who's never had any cancer. Her mother had cancer twice, once at 44, once at 61, both breast cancers. She had an uncle with breast cancer. So you might remember I mentioned male breast cancer is possible but rare. 2 aunts with breast cancer. One of them was earlier at age 45, and then a lung cancer, a brain cancer, a pancreas cancer. So we counseled her that this looked like it could possibly be something hereditary based on the types of cancers and the frequencies of cancers and the ages of cancers. So she proceeded with genetic testing and was found to carry a mutation in a gene called PALB2, PALB2. They name genes seemingly random letters and numbers. They're not random, but it's nothing that you've probably ever heard of. Okay, well, what does that mean? Well, it means that for females with that particular gene, the risk of breast cancer is 40 to 60%. Average risk is around 13%. A slight increased risk for ovarian cancer of about 3 to 5% compared to 1 to 2%. Increased risk for male breast cancer. However, you'll see 0.9% is still a pretty low risk, but I think the average risk for male breast cancer is about 0.1%. And then a slight increased risk for pancreatic cancer. So we manage that with the same types of tools that we would manage for those risks. Here's just a visual representation. I am going to mention the genes BRCA1 and 2, but I don't spend a lot of time talking about them, not because they're not important, but because I want people to understand that that is not the whole story. So another important point is if you or your relative or somebody had genetic testing for hereditary cancer more than 5 to 6 years ago, there's a good chance they were only looking at these 2 genes, BRCA1 and BRCA2. Well, that's not the whole story. So the recommendation there would be to circle back and say, okay, I would like an updated genetic test. But I did throw this slide in here just as a visual about, okay, how much of an increased risk does that particular gene confer?
Lindsay, we have one question in the chat, and this is from a father whose daughter developed colon cancer at the age of 26. And her sibling sister was much younger, but the recommendations that were made to the family were that the sister would start colonoscopy 10 years prior to her older sister's diagnosis.
Mm-hmm.
So she had her first colonoscopy at age 16. And, you know, he was just wondering why was that the recommendation?
Mm-hmm. Somebody must be a mind reader in this group because that's exactly where I'm heading here. So let me switch gears, and that question will get answered here in just a second. So if we have families where cancer is happening at earlier ages or higher frequencies and it looks suspicious for something hereditary, but we do the best genetic testing that we know how to do today and we don't turn up anything, well, that could mean this is in this category of familial cancer. So those are families where we don't ignore the fact that someone was diagnosed younger with cancer because we know that we don't know everything yet about genes. So there could still be a mystery gene that we haven't put our finger on that could be increasing cancer risk in that family. So that is that recommendation of still doing an earlier colonoscopy, even if genetic testing was negative, is for that reason. So I've got some specific examples here. And again, I'm just flashing this back up. We're talking about this chunk of familial cancer here. I think I mentioned all these things. Families also, share environment. So some of that residual risk could be something environmental. Moving ahead. I'm going to get to that. So for breast cancer, let me talk about that for a second. If we have individuals that have strong family history of breast cancer, but negative genetic testing, we still look at their overall risk using some statistical models that predict what their lifetime breast cancer risk is and what their 5-year breast cancer risk is. So if someone's 5-year breast cancer risk is over 1.7, that triggers a discussion about some prevention options, such as medication that can reduce breast cancer risk. If lifetime breast cancer risk is over 20 to 25%, that still triggers a recommendation to consider breast MRI screening in addition to mammogram. So that's breast specific. Ovarian specific, if you have a first degree relative with ovarian cancer, your chance could still be slightly elevated. We don't have great screening for ovarian cancer, but some people still consider doing ovary removal in that situation if they're very concerned. Here's what you mentioned about colon cancer. So if there's a close relative, a first degree relative, that would be a sibling, parent, child with colon cancer, we would recommend colonoscopy begin either at age 40 or 10 years earlier than the youngest person was diagnosed. So that's where that comes from.
Now, you would recommend, and I'm sure that the daughter that had the colon cancer had genetic testing, but you'd recommend that her sister get genetic testing as well?
Well, that's an interesting question. So if we test a person in a family who has had a cancer early and we don't turn up anything,
right,
odds are we don't need to do genetic testing on other relatives because we've already tested the most suspicious candidate in the family.
But if there was a mutation, then
if there was a mutation, then certainly that would mean those relatives would be candidates for genetic testing. Yes. Mm-hmm. So if people have strong family history of pancreatic cancer, they can still, like you mentioned a few minutes ago, Dr. Jagier, they still can qualify for pancreatic cancer screening if they've got 2 or more close relatives with pancreatic cancer. Okay. This might be my last big topic, so send those questions in if you've got them. I wanted to touch on this direct-to-consumer testing. So many people in the community have done ancestry testing through Ancestry.com, 23andMe. What I want you to know is that those companies do offer what they call a health option, and they can provide an extremely limited result in terms of cancer. So let me get into some more details about that. So the last time I checked, 23andMe specifically was looking at BRCA1 and BRCA2, but only 3 particular mutations in those genes. There are literally thousands of mutations in those 2 genes that are not being checked on what 23andMe is doing. Additionally, as you picked up, typically we look, and if we're doing true medical genetic testing for hereditary cancer, we look at 84 genes. So that it's not even a drop in the bucket of what a complete result would be. So what that could lead to is a couple things, false sense of reassurance. If someone looked at that and said, oh, I didn't inherit any genes that would increase my risk of cancer, well, that's not a conclusion you could draw from that. They state in the fine print that if there is something that comes up on that, it must be validated by a clinical laboratory. So I wanted you to be aware of that. I'm not saying you can't do ancestry testing, but what I've concluded is that if you want to put that in the entertainment category in your budget to spend your money on that, fine. I would not put it in your healthcare category in your budget.
Now, is it true to say that not all of those 1,000 mutations in those genes are pathologic?
Well, I think there are probably almost close to 1,000 that could be pathologic, and even more that wouldn't be. Just as an illustration of how complex the genes can be.
So you can have a mutation in the BRCA1 or 2 that wouldn't necessarily translate into the risk of cancer.
If that was the case, it would be in that variant category.
Right.
So, yeah. Another thing I want to mention is, this is kind of a public service announcement. So, not too long ago, we became aware of a company that was taking advantage of Medicare patients who were applying for life insurance and their life insurance salesperson was going through, I guess, the typical type of questions that one would answer when you apply for life insurance about family medical history. And the life insurance person was then saying, "Oh, you look like you might meet Medicare's criteria for genetic testing. Would you like to do that?" And if the person said yes, they then collected a saliva sample, sent it to a questionable lab. And as part of that particular company was doing two things wrong. One, there was no appropriate medical professional involved in that test ordering. And then two, they were overbilling Medicare for the cost of the testing. So my point is, if you're a community member and you were approached by someone other than your physician talking to you about genetic testing, it's not a good idea to go that route. So just be aware. So I think that is all of my formal information, but I feel like I could keep talking for a long time, but I don't want to monopolize the conversation. So I'm happy to answer any questions, go a different direction, whatever you guys have on your mind.
Oh, that was great. I had mentioned to Lindsay also, and we're not trying to, knock 23andMe out of business. I'm sure it does a lot of things, but there was a article earlier this week about the fact that about 7 million of their customers had been hacked for their personal information. And they really were targeting the Ashkenazi Jewish population to sell their information. The Ashkenazi Jews, can you speak to that risk that goes along with that ancestry?
Yes. So not unlike other ethnic groups, through the history of humanity, Ashkenazi Jewish individuals would typically marry and have children with other Ashkenazi Jewish individuals. And so that means that there are specific mutations that are just more frequent in that population because it was a kind of a smaller group of people having families together. And so if you have Ashkenazi Jewish ancestry, if you were full Ashkenazi Jewish ancestry, meaning mom and dad, then the chance for you to carry a mutation in specifically BRCA1 and 2 is 1 in 40. That's regardless of whether you've had cancer yourself or anybody in your family has had cancer. That's just the starting baseline risk compared to the average Caucasian risk to have a BRCA1 or 2 mutation. It's more like 1 in 400. So it is a baseline increased risk. And I don't know much about that story, but it is because I mentioned that 23andMe is typically testing for only 3 mutations in those genes. Well, the 3 that they're testing are the ones that are more prevalent in the Jewish population. So I don't know if that's how their part of their hack was looking at that, but
right. I think there's a larger concentration of Ashkenazi Jews in their inventory there. So, it was a place to go and probably anti-Semitic and whatnot. So now Lindsay works as a genetic counselor in the Center for Integrative Oncology and Survivorship at Prisma. I know that genetic counseling expertise exists at Bon Secours as well as at Gibbs. So this is not a situation where we are recommending in any way that you come to see Lindsay when that expertise exists otherwise. But it is important that you keep attention to your family history. And again, I don't think your doctor is going to ask you about that appointment to appointment. So if something new happens, your sister has a new malignancy, or your father develops something, and you just want to make that evident, please let your doctor know. So I think it's becoming more and more common knowledge that there are cancers that fall into a genetic syndrome, and that probably implies that the doctor would be okay about you being referred. You can also self-refer. And Lindsay, if you want to give your contact information, but I am sure that it's a situation where it would not be difficult for you to find genetic counseling at any hospital you prefer.
Mm-hmm. Yes, we're very open to any person, even if you're just curious. A question that hasn't come up yet is, what if you're adopted and you just have no information about your family history? Well, that's certainly a situation that comes up, and we're happy to help facilitate genetic testing. So yes, we are here available at Prisma for anyone. The only time that a referral is required is if you are a Medicare patient. But most of our primary care doctors around here are familiar with our program and are happy to refer if you just send them a message. And we have a website. So the contact information is on our website. I can't rattle off the name of the website right now, but I'm sure if you Google searched Prisma Genetic Counseling, you would find us. And like I said, we have options that make it very convenient for folks. We have phone consultations where we would, do this information gathering and assessment over the phone. And then if genetic testing was going to happen, we could facilitate saliva samples. So it's very accessible, and we want people to know that. So, and finances are generally not a burden like they have been in the past for genetic testing.
All right, given the fact that they looking at you potentially leaving their screen, we have more activity in the chat room now. So I have a question. I'm a germline BRCA2 CHEK2. My CHEK2 was originally, apropos to our question, a VUS, but I was mailed an update that it is now deleterious. When I mentioned the CHEK2 mutation, my doctors only know about the BRCA mutation. Are there any resources I can share with them beyond the report I was mailed?
Mm-hmm. That's a great question. So it is true that even many healthcare providers are not aware of the increasing list of genes that can increase cancer risk, such as the CHEK2 one that you mentioned. So the first step, I think, in that situation, I don't know if you came through our clinic, but if you did, please contact us back, because we do want to follow up with people every year. If you're wanting to communicate to your doctor that you are established with that information, the first step would probably be to just simply share that laboratory report with them. The patients that we see here that come through our clinic, one of the benefits of that is that once you come through here, we kind of facilitate anything that you need moving forward. So if you get a reclassified result such as that, we would contact you personally, have that in-depth conversation, and bring you back in to get you plugged into what you needed to be doing. But it is a difficult thing, because our primary care providers are wonderful, wonderful people. The amount of medical information that they
have to keep up with,
it's enormous. So it is a story that requires some advocacy on patients' parts. So you're welcome also to contact me directly offline, and I can help see if there's anything we can do to help you get that communicated.
Yeah, but it sounds like a pedigree would be a good thing.
Mm-hmm.
Right. And I guess she's had it done because she's got genetic testing. So contact a genetic counselor at whatever health system you would like to frequent, but we are ready and available, or Lindsay is ready. I'm not the we anymore. If the dad had prostate cancer at age 48 and the mother has been diagnosed with breast cancer at 66, how would you advise the parents for genetic testing two sons, one who is 33 and one who is 29? So early onset prostate cancer, somewhat, and a mother who was diagnosed with breast cancer at a more advanced stage.
Mm-hmm. Yeah. So one of the first things that we do when we look at families is we do look at each side of the family separately, because we're assuming that the mother and the father were not related by blood. So an early onset prostate cancer would be something that would warrant looking into, and the best person to do that genetic testing first would actually be that father who had the prostate cancer, because it's a common question where, you know, the two sons are probably curious about their own risk, and maybe they would even think, well, I should go do genetic testing myself. But really the wiser choice would be to have the father do the genetic testing first, because if he were to do testing and was positive, then that would be a clear answer for those two sons on what that they needed genetic testing. If the father were to do testing and he was negative, then that would mean, well, okay, from that side of the family, there wasn't anything that we could put our finger on that would warrant genetic testing for those two sons. On the mother's side, if that's the only family history, 66-year-old lady with breast cancer, if there's no aunts, grandparents, anybody else with cancer on that side, technically that doesn't raise a red flag just by itself. So that's my 2 cents on that.
Oh, $64,000. Well, I think we've covered most of the chat questions. There's one more question that I will answer later. And I want to thank you as per usual. You just do a wonderful job with a very complex topic. And I think the people really enjoy it. So let's see, this is 23. You'll be back with us in 25. Yeah.
It would be my pleasure.
It's a biannual thing to just keep up with this sort of thing. So, and what we normally do is end with a couple quotes. So I have a quote here from Desmond Tutu, Bishop Desmond Tutu, who is a South African bishop and theologian, and was led an anti-apartheid movement and was the recipient of the 1984 Nobel Peace Prize. And it speaks to what we try to do with cancer prevention and wellness and living a good lifestyle. There comes a point where we need to stop pulling people out of the river. We need to go upstream and find out why they're falling in. And then another quote from Orson Welles, who was a actor that lived from 1935 to 1985, and so not a long time. He was portly, but it was a great actor, great director, great producer. He actually did the War of the Worlds on radio that caused widespread panic around America, but was the director for Citizen Kane and a number of great movies. But he quotes, "My doctor told me to stop having intimate dinners for 4, unless there are 3 other people involved." So we will see you next month, and it won't be on Thursday at 5:30. It'll be Wednesday, November 8th at 5:30. So a little bit of a change in the usual schedule, and that'll be about clinical research and why you should be considering it and considering it for your family members. So Lindsay, thanks again. And for everybody who attended, thanks. And I will give you back your evening. And again, let people know that if you enjoyed this will be available on the cancersurvivorspark.org website. Good night.